Yeah, and also like our student trainees, right? They'll be like, oh, we're going on winter break. Oh, okay, sure. Tell me what days those are, right?
Yeah. I have some projects at other universities. And so I like the grad students of those will be like, wait, you're not at any of these meetings because you're on break. When did your break or when did your semester end?
All right, well, let's go ahead and get started. This is the first speaker of the spring semester, so I appreciate everyone being here. We're really excited to have a local person here right from UNC. We have Dr. Kavita Shah Arora. She's an associate professor here at UNC and serves as a division director for General Obstetrics, Gynecology, and Midwifery. She has a medical degree, but also a master's degree in bioethics, as well as a degree in clinical science research. Her clinical research and education interests center around reproductive justice and ensuring evidence-based and equitable reproductive health policy, and she focuses in particular on sterilization disparities. She has over 100 peer-reviewed publications, and her work has been funded by the NIH, Health Resources and Service Administration, the Greenwall Foundation, and Society for Family Planning. She recently served as the Greenwall Fellow in Bioethics for the National Academy of Medicine and chair of the National Ethics Committee of the American College of Obstetrics and Gynecologists, and has also served as on the National Ethics Committee of the American Medical Association and on the board of directors of the American Society for Bioethics and the Humanities. So we're really happy to have Dr. Arora here today. Right, all right, so here are the obligatory disclosures. And here are the objectives. And so that means and I hope that we can have some time for a rich discussion, because there's certainly one correct answer to the problem that I'm going to lay out. So as background, my work centers, like you heard, around permanent contraception or sterilization. In the 70s, United States had really a terrible history of forced sterilization. Right, some of this came from the World War II Nazi eugenics mentality of a master race. Most of the sterilizations were on women rather than men, people of lower income, minoritized racial ethnic groups, those with sort of medical comorbidities, especially mental health issues. And so this went on for a long time, and I put sort of North Carolina's experience down below. So we in North Carolina performed we estimate about 7,600 forced sterilizations, which makes us number 3 in the country in terms of the number that are estimated to be performed here. In 1919, we actually were the state who passed the first law allowing forced sterilizations, but actually it was never sort of practiced under because it was feared to be unconstitutional. And then by the time they passed a new law in 1929, we were the 17th state to have done it. So lots of states were sort of rushing to do the same thing. And we practiced under that for a little bit, but a few years later, it was declared unconstitutional. So in 1933, they tried again and got a new law passed. And this is the one that sort of operated under for most of the 30s, 40s, 50s, etc. 77% of those 7,600 people who were sterilized forcibly were women, and 60% were Black women. In 2003, that law was finally overturned. There was an apology issued by the governor and reparations paid, and we can chat a lot more about sort of the problems inherent with all of that. But that is sort of the North Carolina focus. Zooming back out to the country, in the country, things sort of happened a little bit differently. So there was a court case in Congress's attention of the issue in the 1970s. And so in 1976, the Department of Health, Education, and Welfare, which now we call HHS, passed a law that said you had to sign a specific consent form, and at that point, wait 72 hours from when that consent form was signed to when the sterilization procedure could occur, as a way to protect against some of this coercion. 2 years later, in 1978, they actually changed it from 72 hours to 30 days. It's unclear why those time points were picked or why it was changed. That's just all we know about it. And then it's really easy, right, to say,
Great, but this is the 21st century. We behave much more ethically now. There are no such things as lack of informed consent and coercion. But we certainly haven't fixed systemic racism. From 2006 to 2010, there's been reports of 150, mostly Latina inmates in the California penal system undergoing forced sterilization. And I mean, you turn on the news, right? Your judges giving reduced prison sentences to female people who are incarcerated in exchange for getting sterilized or getting long-acting contraception. There's hysterectomies being performed by ICE detainees, right? This remains an issue.
Can I just ask a quick question? Were those all women or did that include men?
Of the 150?
No, just for the laws and policies, were they for women and men or were they?
Yes, the law applies to both men and women.
So they were, the 7,600 includes women and men.
The 7,600 North Carolina, yes, but 77% of them are women. And so this is what the federal law mandated, this specific consent form. It doesn't take a bioethicist like me to figure out that is not how you do informed consent, right? It is written at the 13th grade reading level. It is much too verbose. It has inherent sort of lots of problems. And we'll chat more about some studies looking into it in just a second. So at face value, this policy doesn't, right? It's a restriction on autonomy. There is really only one other thing I can think of where there is a federally or state mandated waiting period for a medical procedure, right? That's abortion, right? So outside of reproductive care, we don't mandate that there are waiting periods where you can undergo something that you autonomously desire. Like we talked about, that forms literacy level is much too high. If the goal was to improve informed consent, we haven't done it. There was an interesting study done where they administered a survey to patients after they had signed the form and undergone their informed consent conversation with their OB/GYN. And they asked them 3 questions. Is this permanent? Is it reversible? And can you have children? These are not rocket science kinds of questions. These are sort of foundational to informed consent before you have permanent contraception. And a third of the women got one of those questions. So it's not improving informed consent. And then I want to sort of caveat about my nomenclature, and it's your hand just a second. So the field has moved away from calling it sterilization to permanent contraception. So you will hear me say permanent contraception with sort of 2 exceptions. Sterilization remains a nomenclature for things that are forced without informed consent. And that's the bright line in the sand to permanent contraception, which is what I believe I offer my patients, right, which is with informed consent, which puts it sort of in the spectrum of the various contraceptive methods. This is just one method along that spectrum. And then the only other place that we use the term sterilization now is in reference to the specific Medicaid policy, because it still says sterilization in the federal statute. You had a hand up.
Yeah, I just wanted to know if the forms exist only in English or if they're available in like different
That
languages.
is a great question. It exists federally in English and Spanish. Other states have made other translations available, but not many. And then this applies only to people with Medicaid, and Medicaid insurance often expires postpartum, right? You can get on Medicaid insurance for several reasons. One is based on socioeconomic status, but another is if you're pregnant. And in different states, the length of time that you keep Medicaid postpartum varies. In some states, it ends right after your hospital discharge from delivery. Some states, it's a few weeks. In North Carolina, we just expanded it to 12 months, which is great. But if you don't bring up postpartum contraception with a patient until after they deliver or at their postpartum visit, which many clinicians don't, you sort of miss the window for when someone is eligible in their insurance, right? And this doesn't apply for people with private insurance. So what we really set up is a discriminatory system. And when we try to quantify the amount of impact, we know that anywhere between 1/3 to half of people with Medicaid who want permanent contraception actually are unable to receive it within 1 year postpartum. And up to 1/3 of those patients who don't receive it become pregnant in the following year. You are actually twice as likely to have an unintended pregnancy if you wanted permanent contraception and didn't get it than if you wanted any other method of control. So the people who really didn't want more children, if we don't fulfill that desire, are actually much more likely to than others. And within that subset, there are disparities by race as well. So Black women with Medicaid are about half as likely to get a desired permanent contraception procedure than white women with Medicaid. and Latina women are actually a little bit more likely to get it. So it's really created a two-tier system along multiple axes, right, race. And so that was the problem. And I was a young, sort of bright-eyed, bushy-tailed, naive medical student and encountered this problem and was getting my master's in bioethics. And I was like, this is so clear. This is a problem. We should just get rid of this form. Right, as you heard, I was active in ACOG and AMA and doing like federal advocacy stuff. And so got those organizations together. We went to CMS and we just went to HHS and we're like, we should just get rid of this form. Let's just cancel the whole thing. Here's the data, it doesn't work. And to my surprise, we were met by advocacy groups representing patients and communities who were like, hold on a second. We haven't fixed coercion. We haven't fixed racism. What do you have instead? Let's not cancel this form. And every few years when HHS has an open comment period, the academics and ACOG and organized medicine use the data that has been incorporated and been like, please get rid of the form. This is why it's a clinical and public health nightmare. And the comments from the patient groups and patient advocacy groups are saying, don't get rid of the form. This is why it's still important. And so that is what sort of led me to this research trajectory of it's not getting rid of the form necessarily, unless we have a replacement for how we fix sort of coercion and bias. And also then there leaves the question is, does this policy actually fix or protect from coercion and bias? Perhaps more of a balancing act, right? How do we balance protection from coercion with a barrier to autonomously disparate care? So we started looking at it from a health disparities model. And so like all disparities, there are multiple levels at which those are affected. So this is adapted from Kilborn, so she identifies sort of patient level, clinician level, hospital level, and provider level factors of barriers. So we're going to go through sort of each one of these and the data around each one. So at the patient level, we know that a patient's beliefs and preferences about what method of contraception they want to use impacts their contraceptive decision making. And those beliefs and preferences are impacted by lots of things, like their family and their partner and their race and ethnicity and their culture and their education. But what people don't account for are those preferences are not static, right? You don't make a decision at one point in time and then that is your birth control plan for life. And in fact, the window of fluctuation is probably smaller than we as clinicians acknowledge. So we created a data set when I was in Ohio of 3 years of delivery data for 8,600 patients and looked at every single contraceptive plan they had reported in their chart during prenatal care, during the delivery admission, and up to 1 year postpartum. And categorized here, the categories are tier 1 are your most effective methods of contraception, permanent contraception and LARC. Tier 2 are your short-acting reversible methods, pill, patches, Depo-Provera, those sorts of things. Tier 3 are like condoms. Tier 4 is nothing, and then DC is missing. And only 11% of patients had the same exact tier of contraceptive preference during just one antenatal to delivery to postpartum. Only 11%. So people change their mind. That's normal. It's a part of being human. Also, their preferences are not made in a vacuum. So this is for my current work. This is now a multi-center cohort at UCSF, Northwestern, Metro Health in Cleveland, where I was, and University of Alabama, Birmingham. So 4 very geographical diverse sites with very different patient populations, different clinical practices. And we did sort of the same thing of making this large data set and following them. And then I think at the bottom and the here, that is the people who wanted to be about half of the people who wanted it got it. And then we followed to see what happened after. You can see that they sort of move all the way around, right? And so some of that is because we were unable to fulfill their goal, then that's right. And it's really easy in the data to be like, well, now they wanted to learn, not a large set. But it isn't really, right? Because if the reason they changed their mind is we were unable to fulfill their initial goal, we shouldn't be patting ourselves on the back that they got the lark that they wanted, right? And so what we do and don't do further then sort of sets off this domino path of like how they're change. So we did these dyadic interviews and then there was 176 interviews so each site and then their OBGYN that delivered them, done separately power dynamics. But to try to understand what their preferences were about contraception
question how they got to the decision of wanting permanent contraception. What thought about. So here are sort of some of the patients. The vast majority were certain. Once I made the decision was there. It didn't change. I'm talking about uncertainty, right? About going back and forth during their pregnancy and being unsure if potentially maybe they would want a third child anywhere in the future. And for the folks that were uncertain, there were two pathways that emerged after they got it. Many folks talked about initially having some grief, but feeling affirmed in their decision to undergo permanent contraception, right? This door had closed and they were a little sad. Those patients said, I'm a little sad and think I'm going to experience this again until I'm a grandma. But ultimately, that patient was very happy that she had that procedure, right? And then a few patients did talk about regret, right? Then I won't be able to do that at all anymore. It's permanent. It makes me feel less like a woman. And I don't know, I wish it just would have gotten me a little bit. So then we asked patients during these same interviews sort of what they thought about this Medicaid policy. And did it serve a role in helping with some of this decision-making, certainty and uncertainty, right? That was the whole point, is to help prevent coercion, reduce regret, have procedures that patients actually wanted for them. And these are the positive perspectives that patients had about their waiting period. So some patients talked that it actually helped them minimize regret, right? Like it gave them time to think about, to make sure that this is really what they want to do. Other patients said that the waiting period helped ensure that their decision was made independently, right? Some patients said that initially, just because my mom had the procedure done, I thought it's not that big of a deal. But then when she learned about the 30-day waiting period, in her mind, she thought that maybe she needs to take this a little bit more to consider more of her option. And then other patients commented that during labor and delivery or the immediate postpartum stage, that is not the right time for patients to be making major sort of life decisions like whether or not they want permanent contraception. And so they liked that the waiting period forced this conversation out of an acute time period and into the office where they could. And we'll also signpost that it's an interesting narrative when we then think about all of the other decisions that people make in labor, right? And how do we sort of thread that needle from people have autonomy to make decisions about the body, even in labor. And maybe some of those decisions are not decisions that they themselves may not regret later, right? Like that's really tricky, especially in our contemporary political. Others felt like the form actually served its purpose of protecting from coercion and bias. So one patient said, it's not like a doctor or provider is just going to slip it in there with the other consent forms you're signing on L&D, which I could totally see happening either intentionally or by mistake. But not everyone was obviously positive about the waiting period, right? Some patients and clinicians were negative about the waiting period. So some patients and clinicians said, this was an assault on reproductive autonomy. If someone's decided a person of sound mind, it seems unnecessary. They're not children. Their decision should not be doubted. Other patients brought up that fact that they had a waiting period actually impaired the therapeutic relationship they had with their clinician, because they shouldn't have had to wait, and it was offensive that they had to wait, and that was therefore damaging to the relationship of their clinician. And then many talked about sort of the immediate harm it had to them and their life and their bodies, right? This one patient said, I've been pregnant 12 times. I had 10 children. We started talking about this with my 5th son, and they told me I had to come back. I signed the paperwork, was all prepared for it. Then they told me I couldn't get it done. And with each pregnancy, I had to wait and wait and wait. Others felt like the waiting period actually instilled doubt where they previously would not have had any. So they felt like they were being questioned by the clinician when we would bring up the form or the process or keep bringing it up, and that they could be doubt that set in that you may not have had if you didn't have to wait around for it. So waiting for their decision sort of made them second guess it. And then others had this sort of odd misinformation about it, that rather than a waiting period, it was sort of a deadline that they had to get it done before 30 days or they couldn't get it done. And so then they didn't get it done because they thought 30 days had passed and were no longer eligible.
And then most patients were actually fairly indifferent about it. They were sort of like, it's gonna happen, my mind isn't changing, I have to wait. And then a few acknowledge that tension between ensuring that women aren't coerced into making decisions. All right, so in sum, for the patient level factors, the waiting period is an independent barrier to care, but it also may help with decision-making to reduce regret and coercion. Patients and clinicians have mixed opinions on the utility of the waiting period. And sort of, as food for thought for future discussions, is there something inherently different about reproduction and permanent contraception than other medical procedures, or really any other part of life, right? Like, why do we need a waiting period? Regret is an inherently human phenomenon. There's lots of things I've done in my life that I regret, right? Like, why is it that the federal government has sort of stepped in to hopefully eliminate the possibility of regret for this one specific thing versus having a finger amputated or towing, right? Like any other procedure that people can do. I do think the Kilbourne model doesn't actually talk about patients in communities, and we know communities impact health, and so I do want to sort of throw that in, that we looked at this too. That if you, not surprisingly, if you live in an area with a higher deprivation index, you are less likely to get your desired permanent contraception than if you live in areas with more resources. And this is partially mediated by the adequacy of prenatal care for patients with Medicaid. And that makes sense. If you have more prenatal care, you have more opportunities to sign the form, start the waiting period, and if you're less. All right. Now moving on to sort of the clinician level issues. And so here the clinicians are really like the stopgap, right? Like it is the clinician's knowledge, attitudes, what other competing demands are going on a busy labor and delivery floor, and their bias about whether or not this procedure gets done. So we interviewed, this was a survey that we did of OBGYNs around the country and asked them, do you feel like this is an elective procedure, an urgent procedure, or an emergent procedure? As in, how much priority do you give this? The vast majority felt it was elective. ACOG's policy says it. Then we asked them, so if we go back to that form on the bottom right corner, there's actually two exceptions to the policy. So it can move from a 30-day waiting period to a 72-hour waiting period, what it was initially in 1976 for two carve-outs. One is an emergency abdominal surgery, and two is if someone undergoes premature delivery. I don't know what a premature preterm delivery has been defined by medicine, right? That's 37 weeks. Premature, I'm not really quite sure. And so we asked the OBGYNs around the country, what do you call premature? How do you? Well, they're not really sure either, right? There's a huge variation between what people are doing, 34 weeks all the way to 40 weeks, which is your due date. Which is a problem from a fairness standpoint, right? If one patient is being told 34 weeks, you only have to wait 72 hours, another 40 weeks, like that's a big problem in terms of who's getting it, who's not getting it, what the hospital down the street's doing versus what your hospital. Then we surveyed them about sort of implicit bias. Right, the second column in here is if a patient asks you that they wanted a permanent contraception procedure, what are the reasons that we decline that request? And on the converse, the third column is if a patient didn't ask you, what are we bring it up de novo? What are like reasons you would recommend it sort of out of the gates? Some of these sort of make sense, right? Like if the OR is unavailable, right? So you would decline. If LND is super heavy, delivering, you're just not. Some of the other stuff is a little problematic. Right? The age of a patient, and there is data that there's an increased risk of regret with permanent contraception if people are younger. That doesn't mean all patients who are younger. That certainly sort of brings up like who is the gatekeeper and whose decision. And then sort of on the flip side, when would you recommend it if someone didn't bring it up? Well, past medical history, that makes sense. If someone has peripartum cardiomyopathy and the risk of dying in a future pregnancy is 50%, probably aren't a good doctor if you don't bring that baby relationship, right? But the number of kids someone has impacted their decision, and then the lack of alternatives. So people who practice in religiously affiliated sites or in places that didn't have long-acting reversible contraception, mentioned that they may be more likely to bring it up to patients as like, hey, you can't get this here, but you should probably think about it. We don't have a lot of options. And we'll talk more about religious affiliated hospitals in just a second. But also, even on a survey, a few percentage of docs were willing to say race, education, insurance status, and religion impacted their counseling and performance of pregnancy contraception. Then we did a study where we interviewed docs around the country. This not the sciatic thing in relation to a specific patient's journey. This was sort of just in general about their viewpoints of the policy and public practice. And most felt the policy was super unnecessary, paternalistic, was a barrier to care, and led to adverse health outcomes, like we sort of chatted about beforehand, right? And that it's discriminatory. Some docs were aware of the history and sort of understood the importance of it. A few docs actually liked the policy because it reminded them to do contraceptive counseling during prenatal care, whereas otherwise they forgot. And in a weird way, it would achieve better care to their patients with Medicaid and private insurance because they know they had to start the postpartum conversation in pregnancy rather than waiting out. Of course, they cover every conversation during pregnancy and not waiting to afterwards for that certain time point. And very few docs actually liked the waiting period, and interestingly, male. So then we asked the docs, right? How do you counsel sort of about waiting period? And for those in the back of the mind, knowing that contraceptive decisions COVID and some patients regret it, docs really talked about the discomfort of being an instrument of regret. And so these are the strategies they use to prevent regret. They would sort of hound in, are you 100% sure? No, are you more than 100% sure? Are you 150% sure? Or they would bring up hypotheticals. Let's say your kids all got run over by a car. Would you want more kids? Run over by a car, right? And so like this kind of coercive, really heavy-handed stuff. Others would bring it up repetitively at everything. Are you sure you want it, right? And then this was really common in academic medical, right? We practice in teams, and every member of that team has to feel comfortable with the care they're delivering. And they're probably not seeing the same people each time, which patients got so frustrated with, understandably, when every single visit, the new person would be like, are you sure you want this? Are you sure you want this? And then they show up to labor and delivery, and the 3 nurses and the 4 residents and the 2 medical students and the 2 attendings all ask, are you sure you want this, right? And so how do we sort of work well in a team where everyone feels comfortable that they've provided informed consent and not hound patients? And then other docs said that they just told them any of these before tactics, they felt somebody sort of winced or were a little bit unsure or noticed any hesitation, they would be like, well, we should just do an IUD instead. Others talked about inferring on patient characteristics, right? That if they were young, they would counsel against it. Or if they had fewer children, they would counsel. Others talked about marital status and partner goals being really important. So that in this patient's case, that the patient was going to get a female permanent contraception procedure if she was going to have a C-section, but her male partner was going to undergo a vasectomy if she had vaginal delivery. And that made the doc feel much more comfortable about providing it because the partner relationship was committed to permanent. And they also talked about sort of different tactics of how they brought up counseling and workarounds, right? So if somebody had had 10 children and that form hadn't been signed in advance, they would just backdate this legal form to make sure that it hit the 30-day mark. Some docs talked about their hospitals being an additional barrier to care. So some hospitals, because there are financial repercussions, which we'll get into in just a second, about not having a valid form, their hospitals weren't willing to lose that amount of money. And so their hospitals had to approve that the form was filled out correctly. And if they didn't have that approval prior to that patient going in labor and delivery, the doc wasn't allowed to. And then lots talked about being frustrated with their state Medicaid offices in terms of being unaware of what the rules are, right? Is it 34 weeks? Is it 40 weeks? Why does this form get rejected? Like, what is the correct way to fill it out? What is the reimbursement issue? There's lots of urban myths circulating in the OB/GYN community, right? In terms of what it is. Some people think you just don't get reimbursed for that surgery. $3 package insurance. cares. Other people say you don't get reimbursed for the entire delivery, hospitals are gonna care. Other people say you don't get reimbursed for the entire care globally, that includes the anesthesia, you know, the hospital bed, all of that stuff. Hospitals are gonna care, right? And so like that lack of knowledge of what the ramifications are drives very. And so in some, the attitudes, beliefs, and experiences of OBGYNs are complex and diverse, and there's significant gaps in knowledge of what the policies actually are and what the relevant national guidance is and how much of a priority this should be. And almost all share concerns about the ethics and the impact on patients of this policy. And then there were a minority of clinicians who talked about, we do sort of paternalistic counseling, that stuff to implicit bias stuff, and essentially overemphasize that. All right, hospital level. So this is about health services organization, financing, delivery, healthcare organization. You can pretty much tell you there is a I can count on one hand probably the number of hospitals in the country who have a high postpartum sterilization from contraception. Most don't. And the reason is because labor and deliveries are busy and they're losses, right? No hospital's making money. They're not going to have more ORs and more staff. And if you had to choose between an urgent C-section and a postpartum tubal, people choose the urgent C-section, right? So there just isn't availability. And so it's really hard to get these done unless an organization commits to OR staff, OR space, and all of these resources. The other layer of complexity is the religiously affiliated healthcare institutions. So 1 in 6 births in America happen at a religiously affiliated hospital. 1 in 6. And if you look at the map on the left, here's sort of where they're spaced out. And the orange ones are where this is at the county level, like what percentage of births are in Catholic hospitals. The orange and yellow are where essentially they have a market share of the county. It's kind of spaced out, right? Other than sort of like here in California, so it's okay, people have options. But that B, I think, is more telling because we overlaid it on the maternity care debt. Not all of those communities actually have them. If you look at the number of births, you see that there's wide swaths of America that are in white here, as in there is no option. So if you're delivering, you know, somewhere in Kansas or wherever this orange thing is, the only option you have is a Catholic hospital, and there's nothing in a 3-county radius for you to deliver at otherwise. So you don't have an option to be referred elsewhere to get your food. So OR availability is a limiting factor that can be impacted by hospital, clinical, and staffing policy. You can choose to make this priority or not. There are barriers that can be mitigated by outreach efforts. There's interesting studies done about better inpatient staffing, creating schedule blocks for this, counting it as an urgent procedure, not an elective procedure, and prioritizing it like other urgent procedures, or scheduling it as an expedited fashion postpartum. So what generally happens is we fail at getting it for people during their delivery episode. So we say, don't worry, we'll reach out about it at your postpartum visit. They come back and talk to us at their 4 to 6 week postpartum visit, and we're like, right, we'll get you on the books. Our next available is 3 months from now. And they're already back at work, right? And maybe if they live in a state that hasn't expanded Medicaid, they don't have insurance. And who wants to go through another surgery and figure out childcare and all of that kind of stuff when they probably are a job that doesn't actually even provide paid parental leave to begin with. And so then some studies they've done this expedited scheduling trial, where the patient gets scheduled for the OR and for their postpartum visit by hospital discharge. So when you're leaving, if we sort of failed you initially and not done it while you're inpatient, you have 2 appointments at the month mark, the outpatient visit and the surgery. So at least that you can get it done a little bit. So is it perfect? No, but it's a start. And then, of course, religiously affiliated healthcare systems have an ethical obligation, right, to disclose that they're religiously affiliated, transfer, and be mindful of the impact, but their ability to transfer is minimized by geographical availability. All right, policy level barriers. So this is where sort of the Medicaid waiting period comes in, sort of the reimbursement issues and the administrative burden. So we were curious about what is actually the impact, right? So the 1/3 to 1/2 of people with Medicaid statistic that I gave you earlier who want this don't get it. Are all of that because of this form, or is it because of these other barriers, right? Is it because there's no OR available? Is it because we're racist and biased? Is it because they're delivering in a Catholic hospital, so what they're gonna get done no matter what insurance they have, right? So how do we quantify the actual impact of this federal policy? And so what we did is we looked at the subpopulation in our cohort that were undergoing C-section. And the reason for that is they have an OR, they have staff, they have a surgeon. Literally the only barriers are if the patient changes their mind or they don't have the medication, right? There are no other barriers. We sort of isolated the rest. And in this cohort, yes, 91% of women with private insurance were able to get their contraception procedure and 77% of people with Medicaid. So I would say that relative risk of 85% is probably the true impact of the Medicaid policy. And of the about 90 so people in the study that didn't get it, that had Medicaid, 2/3 didn't have that. So 2/3 of that sort of gap was because of that form. And then the rest was because it was surgically inaccessible at the time, it needed scar tissue, and then about 10% had changed them. And so I think we have to acknowledge that in policy, right, that this is not sort of this, our decision-making is complex.
So, yeah, the 30-day waiting period for those women that was taken care of during their pregnancy? Like what,
6% of the time it was not.
but that, it can be done. They can agree during their pregnancy that they.
And so what happened in these cases is either somebody initiated prenatal care late, right? Social determinants of health issues, and so they didn't have the baby. Or they delivered earlier than we had planned, and so even though we signed the form, we should have signed it a few weeks early. Or we didn't talk to them about it, and therefore the form was never brought up. Or they filled it out, they signed it, and somewhere in the scanning process, it got lost. Right, so any one of those things happened, all of which are different than the route for privately insured patients who don't have to deal with any of that, right? Who could show up that day for their C-section, like, I want my G done, and theoretically get it. So then we talked to the Medicaid administrators in each, right, to figure out, there's a lot of sort of the big black box of what is the policy, what is it supposed to do, how do you review it, what are the financial implications? And mostly what we heard is that they operate out of a sense of fear. So the Medicaid, as we know, is federally funded but state administered. And all of its procedures are supposed to be paid by federal funds. And so state Medicaid officers were worried that if they made any changes to this policy at all, the feds would put them on the hook for the bill. And so mostly they didn't. And so they were kind of unwilling to make changes, even though they recognized, most of them, that this was a problem. A third of states had made some modifications to the form, and some of those included changing the age of consent. So the age of consent is 21. You can't get it younger than that federally, but some states have lowered to 18. Idaho had lowered to 15. And the way they do that is they use state funds to make up. So if you're 16 years old and you want permanent contraception and you get it, Idaho will use state funds to pay for it. If you're 22, they'll send a bill to the feds. Some states also had extenuating circumstances that they would move from the 30-day to 72 hours. That would be things like late to prenatal care, late Medicaid coverage, substance abuse. I say that because that's what's on the form instead of substance use disorder, which is really problematic, right? In terms of stigma, in terms of the population that we want to get pregnant versus the population we don't want to get pregnant. And these states are like, well, we don't really want to be prejudicial in getting pregnant again. We'll make it easier, so that you can right? We'll make it 72 hours instead of. Some had made male-specific forms that were just easier to get done. It tends not to be a barrier for vasectomy. And the reason for that is the vast majority of people getting vasectomies in the United States are white privately insured men in heterosexual relationships. The vast majority of people getting female permanent contraception are Black women with Medicaid insurance. And so then sort of there's the socioeconomic issues, the race issue, there's also who carries the burden of contraceptive responsibility in a relationship, right? And so this is not sort of typical. And then also, if you are male on Medicaid, you typically qualify because of socioeconomic status, right? It's not generally acutely of a time limited thing. Versus if you're female on Medicaid and you qualify solely for your pregnancy and you lose that insurance after you deliver, this is now sort of an administrative barrier. So there isn't as much data around this policy for men. And then other states have actually gone the opposite way and added additional protections to really stay true to the mission of protecting those. So they required a third-party witness to sign off on it. They required the patient to sign one more time. So the patient only has to sign once to start the 30 days. The surgeon has to sign twice. Initially that they did the counseling and then they did the procedure 30 days later. That's probably not the signature that you want 30 days later if you're looking for consent, right? It's probably the patient's signature that you want the second time. And so some states had asked for that. Others actually asked that the form not be filled out by the physician at all and be completely filled out by a third party so that the physician couldn't coerce someone into doing it. So then we asked them those pesky questions about sort of the lower right of the form of how do you all define premature labor? Docs are confused. Medicaid officials are confused. They don't also know. So states define it differently. Some states say any day before the due date. Others have this complex thing that it's any day before the due date, as if the patient delivers before then, as long as it would have been 30 days if the patient delivered after the date. Others make sort of random lines in the sand of gestational age. Then we asked, well, what about that emergency abdominal surgery? C-sections count. And a few said yes, but the vast majority said no, C-sections don't count as emergency abdominal surgery. We can include other GYN things like an ovarian closure and tough. And others said it had to be non sort of women's health surgery completely. So if somebody was having their gallbladder taken out and been 72 hours, you can do it, but not, they had an ectopic. Then we asked sort of, why are reasons you reject this form? In some states, the rejection rates are as high as 40%. So these are not a small volume of these forms being rejected. So like, why do you reject them? Some because the form hasn't been filled out completely. Some because the dates and times are mismatched. This is mostly for patients who are Latino, right? And so if you put the day and then the month and then the year, but then your surgeon puts the month, the day, the year, they'll reject the form. These forms, not only is there a 30-day waiting period, but they expire 180 days later. So if you signed at the beginning of prenatal care because you were pregnant, you were super adamant, this is what I want, and then you get to, it doesn't happen during the delivery, and then you get to your postpartum visit, and they schedule you 3 months out because that's our wait time for surgery right now. The form's already expired, so we can't do it. Others, there's an expired version. So like most government forms, they renew it every few years. Most of the time, they just change the date, right? The expiration form on it. But if you were pregnant now and you signed the form, and in October, they change it to a new version, your form is now invalid. So you have to restart your whole waiting period process. Others, if you can't read your handwriting or signatures, you guess how many doctor signatures you can read, right? They will reject all of those. Others, if you put a patient sticker on the form, that's how you get things scanned into the medical record. Others, if you have mismatching terminology. So there's so many words for these procedures, right? Tubal ligation, you could put the actual surgical method, you could put sterilization. And if it's each time it doesn't say the same exact thing, it gets rejected. Others, if the gender doesn't match the sex, which is a big problem for our transgender population. And then interpreter related factors, like the interpreter didn't put their phone number down or their name down, things when we don't have the language that we need. So this was North Carolina's answer. North Carolina actually has done a good job. There's been a few states around the country where there have been state champions that have really worked with the Medicaid administrators and tried to get some answers. There's only about 4 states in the country that have done this, but in those states, the rejection rates are lower and there are more clear answers. So typically there aren't instructions available on how to do this, and the policy is just that form that I showed you, and people are supposed to magically know how to fill it out and magically know the reasons it gets rejected. and magically know what are the repercussions when it gets rejected. North Carolina has thankfully in 2019 updated, so they actually have a 19-page policy that takes you line item by line item how to do this correctly. And they actually allow you to correct it. Many states are not allowed to correct it. If you fail once, sorry, rejected, not able to done. In North Carolina, they'll send it back and you are allowed to cross out what you did wrong or start a new form. That's nice. And they allow self-injectomy, so removal of the whole tube, rather than just sort of removal of parts of the tube, which is sort of the older way of doing it. Not all state Medicaid offices allow that. But they haven't issued clarification on whether a C-section counts or what a premature delivery is. So in sum, at the policy level, there is a complete lack of clarity and transparency. There's significant variation from state to state. And the Medicaid administrators are unclear regarding what their role and authority is, and frankly want to have clarity about what they are allowed to do and not do. And it is an independent field. And so that's sort of the main thrust of my talk. And I have 3 sort of separate discussion points to get us started, but I'm happy to take questions about anything else or talk about other stuff as well. So one is in this balancing act of not being a barrier to care that is autonomously desired and serving as a protection mechanism for coercion, is a consent form the way to do it? So what is the role of informed consent in protecting against the vulnerable? Or are there other ways we can think that we should protect against people who are marginalized? What is different about permanent contraception and reproduction? There are a lot of things that are wrong in our incredibly racist society, right, and healthcare system. So what makes this different than everything else? And should it be, right? And I will fully acknowledge that patient advocacy groups that are very concerned about why this is different have a point, right? Like if we lived in a totally just world, you would be able to get your permanent contraception procedure one day. You could potentially change your mind because you're human, you're allowed to do it. And then you could get IVF or surgery to reverse the tubal ligation procedure the next day. But we don't live in a just world where that's possible, right? IVF isn't covered by most Medicaid plans, and tubal reversal isn't covered by really any insurance product, right? And so their point of why concentrate on fix on this aspect of it without thinking about sort of this part of that linear trajectory for patients makes sense. And then finally, what is the role of what we do in academia to advocate under sort of a reproductive justice platform, right? It's really easy to publish papers from our ivory towers and say, this is a problem, this is a problem, this is a problem, we should get rid of it. But how do we engage with patients, communities to actually ensure that it's their views and their goals for those policies that are being represented? So I will leave it with that and see what questions or thoughts you have about any of that.
I have like 2 quick questions. One, the judges in California that you brought up, I didn't understand why were they influencing people to get to get that procedure done. And then the second one is when you were doing research for patients, did they bring up or like grapple with religion and their like decision making?
Yeah, those are great questions. So in California, it was mostly a lack of consent in the California penal system, but there have been judges in several states, Tennessee being probably the one that happens most frequently, where judges will say you can have 30 fewer days in your sentence if you decide you want an IUD or contraception, and use that as like a bargaining chip for people. And in terms of why, I mean, bias, racism, sort of our viewpoints of who should parent and who shouldn't, and whatever a good mother looks like, right? And your second question was?
Oh, the patients and whether they like brought up or grappled.
Oh, religion, yes. So yeah, in the sort of contraceptive decision-making part, Religion did come up. These interviews were also done Perry Dobbs releasing. So we also talked about how Dobbs influenced their decision-making as well. And so and clinicians would bring that up too, right? In terms of, does my religion allow me to perform the surgery or not? And so it certainly is one of those things that influences both patient decision-making as well as clinician behavior.
Thanks.
Can you talk a little bit more about like the way that providers and ACOG view urgent versus elective? I wasn't quite sure in that classification difference.
Yeah, I'll give you an example for something we're clinically struggling with at UNC. So we have tiers of OR. Class A through, I don't know, I think it's 2 years. Class A is super emergent. Like, you don't stop at pre-op, you don't you go straight to the OR. So somebody is an ambulance, right? They come in on a helicopter, they go straight to the OR, they don't go anywhere between. And then there's sort of shades of gray towards something super not time sensitive, right? Maybe cosmetic surgery, okay? And everything sort of in between. And how an OR sort of fills up its day is you have scheduled cases, but then you have space for more urgent add-ons, and those get prioritized by what class. So we'll never be able to predict this person is going to deliver on this day, that, and they're going to want permanent contraception afterwards, so let's book them 30 days in advance. Like, we're not going to. So we're always going to live on this sort of what we call the late post list, right? And sort of at the mercy of how much OR time is available after all the scheduled cases are sort of accounted for. And in the 2 OR rooms that are held available for urgent add-on cases at UNC, it's decided based on this classification system. The A's will bump everything else, then they'll work through the B's, then they'll work through the C's, and if you're working through the C's and an A comes in, they go next, right? Like that kind of thing. And so that's where the urgent, elective, emergent thing matters, because if you have a bunch of people who don't value this, they're like, well, this is an elective procedure. They can just get it done later. So it goes lower on the list, and this other person is going to go first. And that's sort of what clinicians think of it, right? They're like, this isn't super important. This is elective. We'll just take care of it later. But that means you're not advocating for that patient to get it done. And ACOG, because of its public health implications of not getting it done, and the clinical implications of the risk of unintended pregnancy, believes it should be urgent, right? And so here we have reclassified these as class D, and then they should happen within 24 hours. Is it perfect? No. Does it always get done in time? No. And sometimes we post it and they call for the patients at 3 a.m. And the last thing somebody who just gave birth and is trying to figure out breastfeeding and dealing with a newborn is saying, well, I'm going to starve the whole day because it could be at 3 p.m. or 3 a.m. But then magically they'll call me and then I'll go, right? Like, so patients often say no, understandably, because we've made them starve for 24 hours and try to figure out breastfeeding and sleep and a newborn. But at least it's classified in the right urgency, right? There's sort of other systems issues that like more OR scopes, right? That more cases could go, because it's not just these cases that aren't being done in a timely fashion. Does that answer that?
Yeah, thank you.
So before you even get to this like step with the forms and all of that, like, is there a bias in providers not even really like counseling a permanent contraception and like leaning more towards LARCs? Just like based on like their personal.
Yeah, I think it falls into buckets, right? People just don't bring it up a lot of time. And who we bring it up for at all, contraception in general, and who we don't, probably varies based on race, education, parity, all that stuff. And then what we bring up in our counseling, right? They've done studies where they have had the same exact patient vignettes and changed the race and changed the clothing that someone wears, and clinicians will counsel them.
I guess speaking of that same thing, I'm kind of curious about the like survey instrument that you provided to doctors, and specifically about like the race question and the education question. Like, what was the format of the question on the survey? Because I feel like there might be a difference maybe in saying like, would someone's race affect this versus if you were counseling a Black person, what would you say? Like, you know what I mean?
Yeah. So yeah, it was a completely an imperfect survey. Right, the better way to do it are sort of those randomized vignettes that I
Right.
can chat about. or, we're interested in doing sort of like a DCA, right, where you just change aspects of the vignette and send it out to lots of people and see how it impacts the counseling and provision. But we actually asked it the former way. So, yeah, the data is definitely limited.
So I've worked a little bit, awesome job, by the way, super interesting stuff. With the, like, the idea of changing policy and how it gets done, and there's this like thing that's just gets stuck, right? That's the way we've done it. Like, I have two questions is, do you think it, well, one thing is, what would you think about if you didn't have to deal with the current 30-day thing? Like, what would you do to protect people with that? And then do you think that it's stuck because it exists now as a consent form 30 days? Like, what are you thinking as far as moving forward, or the best way to do this?
Yep. So in terms of next steps, it's also tricky because it's reproductive health. And depending on who's in the White House and what our makeup is, anybody's goal is to do this both. We had a window of opportunity, years. And so HHS actually convened some listening sessions. 14 patient advocacy groups, ACOG, and chat. We just hashed really frank on this is where there's data, this is where there's not. Let's hear your concerns. And we sort of made recommendations in several areas. Like, one, you can't start the 30 days at time of determination. That makes no sense, right? Like 30 days later, if you change your mind, you don't have to go through it. But you're there in the healthcare system saying you don't want to, right? You can't sign this form if you have, in theory, depression, anxiety, or mental health issues. In practice, most of us just sign it for people because having depression doesn't mean you don't have autonomy. But like those sorts of things are easy fixes that everyone could agree needs to just be strict. Other things are like, you should clarify some things. What is a premature date? That's something. What is an emergency diagnostic, right? Like these kinds of data gaps were really easy that everyone just. And then the other stuff we don't have data about, right? So if it's not 30 days, what is it? Is it 72 hours for everyone? Is it 0 hours? And we got to figure out a different way to do it. That's not this form, this policy. And so the consensus we came up with was, well, there's all these exceptions that go from 30 to 72. Why don't we just start with 72 for everyone? That gets rid of all of these exceptions. In the meantime, we'll continue to work together as stakeholders. There is work being done on a better form of an active decision-making aid where you have to sort of go through the initial and think about this. That might be a solution, right? Is no waiting period at all, but like, let's just do better consent and better counseling. And maybe it's a two-part thing where you do one part sort of separated from the clinician and then one part in the clinician, right?
That's what I was wondering about is like if there's a role of the clinician, what do they like? You're kind of protecting one person, but it's one's kind of in theory from their own decision and other from coercion. It's like, is melding that into the same thing the right
Yes,
way?
I don't know. And so that we left alone. And we don't have that. At this point, don't get rid of it all because we will only do it. And so that got approved, and it's at the budget office. So who knows? It may never end up happening. It may end up happening. I just don't know really, like the black box policy, like who knows? And in the meantime, we are working together with a community-based respiratory research network in Michigan to follow up on this and ask patients themselves, what do you do? And hopefully we'll have that aspect. So it's not just data about impact, but really data about what patients.
Has there been any discussion about the populations, like the people in the prison system or people who are facing a court or, a judge about doing anything about that? Because that seems like a very vulnerable population.
Yeah. I feel so.
Yeah.
Yeah, so yeah, we have a supplement for that. maybe it's vegetarian research, we just got a supplement for people who are incarcerated. So most states don't allow permanent contraception for people incarcerated given coercion potential. North Carolina is unique in that. And so we figured we would just ask pregnant people who have experienced incarceration in North Carolina, what was your experience? Did you feel coercion? Did you not feel coercion? Did you get your permanent contraception procedure? You think of it now. And then we'll have some answers. Probably no questions.
So, what is ACOG's role or engagement in terms of training providers? So one woman comes in and says, you don't want permanent contraception, right? And then the other one comes in and says, you might want permanent. I mean, like, what role are they playing in that, addressing the bias?
Yeah, the really hard thing about this is we haven't figured out how to do contraception counseling correctly. Every sort of screening thing that has been tried, every sort of like, this is how you talk through it, other research studies find problems with. And so we don't know what the right way to do this counseling is clinically. And so then in the ACOG guidance, it talks about, right, like there are these frameworks, you can use them, but here are the pros, here are the cons. At the end of the day, it comes down to doing it longitudinally, using shared decision-making, being aware of your bias, like all of this stuff. That's really great from a framework perspective, but we don't know yet how to implement it on the ground.
All right, we are out of time, so thank you very much for this wonderful work.